Starting with the complications of cataract surgery. When we are reading the complications of cataract surgery, guys, we can divide them into three heads as is written on the screen. Number one, operative, or I can say intraoperative. Yes, whatever complications are occurring during my surgery, what I can notice during the surgery itself. Then, obviously, there can be acute post-operative and late post-operative. Self-explanatory. We start first of all with the discussion of the intraoperative or operative complications of cataract surgery. Number one, the first main important complication that we're discussing here is something called as PCR. Full form is posterior capsular rupture. Now, let me give you the steps of the surgery. We don't want to rupture it, we don't want to destroy the posterior capsule of the lens. We only want to create a CCC. But if our hydrodissection is not completely done, that means the capsule has not been separated from the cortex. So when we are removing the cortex, then the capsule will also get sucked up. Or usually, if we are not careful during nuclear fragmentation, when we are trying to break the nucleus, if our instrument depth is not correct, we can even break the posterior capsule. That will lead to posterior capsular rupture. Yes, you understand this? Now, if posterior capsular rupture occurs, let me just draw an indicative diagram for you. Let's say posterior capsular rupture has occurred superiorly somewhere here, and then there is another, right? Then the IUL which I implant, the intraocular lens, will it be able to remain stationary? No. It will do what? It will have no support from the backside, so it will fall into the vitreous. Okay. So PCR creates problems with IOL implantation and with vitreous moving into anterior segment. Okay, we also call it a rent. Okay, now when there is a PCR, the first challenge that comes is where do you implant an IUL? So IUL may be implanted, we already know the sites of implantation. So because of capsular bag now not being cohesive, not being patent, it is ruptured. IUL may be implanted either in the sulcus, I hope you understand, in the sulcus, which is PCIUL, between the anterior capsule and the iris, or it may be implanted as an ACIOL. So that means the question is, can you implant a PCIOL after PCR or posterior capsular rupture? Yes, you can, because you can implant the IOL in the sulcus. Alright, I hope you are clear about PCR as a complication. Yes, it will lead to IOL falling down into the vitreous. Now, the second complication that we need to understand apart from PCR is UGH syndrome. UGH syndrome. Now, UGH obviously is three letters, so three words. U for uveitis, G for glaucoma, and H for hyphema. Uveitis, glaucoma, hyphema syndrome. Three things are occurring. Uveitis, that is inflammation of uvea. Glaucoma, that is blockage of trabecular meshwork. And hyphema, that is, yes, that's the new word if you have not heard it. What is hyphema? Hyphema is, if you don't know, please, I'm writing on the screen for you, collection of blood in anterior chamber. Collection of blood in anterior chamber. Now, we know the full form, uveitis, glaucoma, hyphema syndrome, but the question is, why does it occur? So it occurs due to ACIOL implantation, which leads to iris chafing. Not just a fancy English word, I will say iris chafing. What do you understand by chafing? Chafing means rubbing basically, yes? So now, if I implanted an ACIOL, if this is my iris and my pupil, this is where my IOL is, ACIOL. If you understand, it is resting over the iris. But now iris and pupil, they are mobile structures. See, the pupil will constrict, the pupil will dilate. This is my ACIOL, this is my pupil, and obviously peripherally it is my iris. So my iris will move, my pupil will constrict, my pupil will dilate. When my pupil is constricting and dilating, what is happening? The iris is rubbing against the IOL is stationary, but iris is mobile, pupil is mobile. So when my iris is continuously rubbing against the ACIOL, I am calling it iris chafing. Okay, just like we shaft or we rub smoother a wood, yes, so it is getting smoother, you can say. Now when I'm rubbing iris over and over again, it will lead to inflammation of iris. Iris is a part of uvea, so there will be uveal inflammation. Iris is a pigmented tissue. Pigmented tissue, when rubbed, pigment will release. Pigment will block the trabecular meshwork. When pigment blocks the trabecular meshwork, it leads to glaucoma. Now, iris is a vascular tissue. Because iris is a vascular tissue, when I rub it, what will it lead to? It will lead to bleeding. And where will the blood collect? Obviously, the blood will collect in the anterior chamber, which is called as hyphema. I hope you are clear about this. That is a complication specific to ACIOL. If we see such a complication, then we either need to give steroids and anti-glaucoma agents, or we need to explant an ACIOL if we think it is becoming severe. Alright, now, complication number 3. The third intraoperative complication that we need to be aware of is expulsive choroidal hemorrhage. Expulsive choroidal hemorrhage. The choroid in the posterior segment is heavily vascularized. Due to the pressure differences when you are doing the surgery, we open the eye, the external pressure and the internal pressure. So all the contents of the eye are getting sucked out. If you are not able to maintain correct pressure inside the eye, then due to the sudden pressure differences, due to the sucking action of the outside air pressure, the choroidal vessels may burst or may hemorrhage, and that will lead to expulsive choroidal hemorrhage. The only question that the examiners ask you here is what is the source of bleeding? So the answer is in the question. The hemorrhage will occur from choroidal vessels. If you remember the basic anatomy, what is the blood supply of choroid? Yes, the blood supply of choroid is, if you don't please learn it again, short posterior ciliary artery, which supplies the posterior portion of the sclera, the choroid, and the outer 4 layers of the retina. Also, short posterior ciliary artery, which pierces the sclera around the optic nerve. Quick review of your blood supply. Alright. Now, another important complication which can occur if we are not careful during the surgery is Descemet membrane detachment. Descemet membrane detachment. See, it is pretty easy to understand if you understand the planes. This is my cord. This is my iris. And this is my lens. All the instrumentation that I have is going through the cortical clear corneal incision, and the plane has to be somewhere here. I need to do the surgery near the lens. But if during entry of the instrument or during removal of the instrument, the surgeon is not careful, then what may happen? That the instrument may forcefully rub onto the inner surface of the body. And when that happens, a lot of times we see that a small portion of the Descemet's membrane may become detached. So it may hang down, like you can see in the diagram here. A small portion of the Descemet membrane starts hanging down. Right? When it hangs down, it can lead to corneal edema due to damage. So what do I need to do? I need to inject an air bubble. Now this air bubble, through upward pressure, will slowly push the Descemet's membrane up, and in a day or two it will reattach. So what is Descemet's membrane detachment treatment? We say desmetopexy. Desmetopexy. So basically we are injecting an air bubble in anterior chamber. Desmetopexy. Okay, pexy means basically trying to put pressure on something and lead to reattachment. That is pexy. So desmetopexy, that's the name. Through air pressure. Alright, everybody. These are some important operative complications of cataract surgery. The most fearful complication that as a surgeon we always want to avoid is PCR, because whenever PCR occurs, the case becomes complicated unnecessarily. The vitreous leaks out. We have to do vitrectomy. We have to think about implanting an IOL in a special place, either in the sulcus or in the anterior chamber. And the visual outcome, even though it is good, the prognosis is good, but it takes extra time for rehabilitation. Usually after cataract surgery, the patient will regain 6/6 vision or complete vision within the next probably 12 to 24 hours. Yes, obviously the medications will continue for longer, the post-operative medications, but the vision will be regained. But if the patient has a PCR, then the rehabilitation becomes a slightly longer issue. Maybe 7-10 days are taken to regain the complete vision. Right, it's done. After we have the operative complications, we move on to the second group of complications, and that are the acute post-operative complications. Acute are basically we are trying to say complications which occur immediately after the surgery. Okay. Here, the most important complication that one should always notice is iris prolapse. See, we had made an incision in the periphery of the cornea. Let's say this was the incision. Okay. Now, if you are not careful in sealing this incision, if due to pressure differences, again I'm saying, see, the air pressure is lower than the eye pressure, so everything gets sucked out. Because of this, if the iris gets stuck here, if the iris goes out, yes, then it is a issue, because number one, the tissue is going out. Number two, that means there is a gap which is allowing the outside element to get inside the eye. suture it or whether we close it by water pressure, whichever way we close it. Okay. Now, number two, the second important complication that you need to understand is the one word I'm writing on the screen: endophthalmitis. The severity of this complication, I think the name itself is telling you, endophthalmitis. There is inflammation in the eye, itis ophthal, and the inflammation is so severe or can be so severe that it can completely damage my eye or end my eye as I know it as far as vision is concerned, right? So it's a severe complication. We take all precautions for sterility to avoid infections, yes? And that is the word we are wanting to avoid, endophthalmitis. Now, what is endophthalmitis? Let us try to define it if you understand the emotion behind it. Endophthalmitis is suppurative inflammation of all layers of the eyeball except sclera. Suppurative inflammation of all the layers of the eyeball except the sclera. So the first question that can be asked, you can see in the name only. They will ask you all the layers of the eyeball are affected in endophthalmitis except which layer. The answer will be sclera. Yes or no? Now the second question, which is also seen in the definition itself, is which type of inflammation it is. Suppurative. Suppurative means what? Suppuration. Suppuration means pus. Yes, very good. So if there is pus, that means the etiology, if I can say so, is infective. There must be some microorganisms that are causing the accumulation of pus. Yes or no? Suppuration. So that is where my questions start from. Etiology. Most common cause of acute onset post-operative endophthalmitis. So I am saying acute onset post-operative. After the surgery, there has been an acute onset. The definition for acute onset is within 7 days after surgery. Alright, obviously post-operative means after surgery. So we are saying within 7 days after surgery, the patient had endophthalmitis. What is the most common cause here? The answer to this is Staphylococcus. But as soon as I said Staphylococcus, a lot of you said Staphylococcus aureus. No, that is not the answer. See, everywhere your favorite bacteria cannot cause everything. I know Staphylococcus aureus causes a lot of things, but not everything. So the answer is Staphylococcus epidermidis, which if you have read your microbiology, which I hope you had, you may remember is also called as coagulase negative staphylococci. Yes, we classify staphylococci based on two reactions: catalase positive, catalase negative, and coagulase positive, coagulase negative. Staphylococci is coagulase negative staphylococci. So in a lot of times option C or coagulase negative staphylococci is even mentioned. Now, apart from the fact that endophthalmitis can affect in the acute post-operative period, it can actually also affect the eye in the late post-operative period. So even though we are discussing it under the acute post-operative complications, it can be late onset also. So most common cause of late onset post-operative endophthalmitis. Alright. Now what is late onset first of all? Late onset is usually when endophthalmitis starts after 6 weeks of surgery. The onset of endophthalmitis is after 6 weeks of surgery, and usually it can occur till 6 months after surgery. Okay, so 6 weeks to 6 months after surgery, that is the time point for late onset. Now, again, what is the microorganism which is implicated here? So the microorganism which is implicated here is gram-negative bacilli, which is Propionibacterium acnes. Okay, so given the name, because it is also responsible for the acne or eruption during the teenage. Okay, now, third most common cause of post-traumatic endophthalmitis. See, trauma can also lead to some kind of a penetration. If there is a penetration, it can also introduce infection inside the eye. So we need to know the bacteria here also. See, so even though we are reading endophthalmitis under the acute post-operative complications, we are discussing the whole topic. Okay. So the bacteria here implicated is most commonly Bacillus cereus. Now, all these are exogenous causes. If you understand, yes, the bacteria will come from outside during surgery, if sterility is not maintained, or during trauma, due to some penetrating traumatic agent. But what if it is an endogenous agent? Endogenous endophthalmitis, most common cause, again I'm saying most common bacterial cause, let me say. Most common bacterial cause in India and Asian countries is Klebsiella, whereas the most common fungal cause for the same is Candida. Okay, these are our questions on the etiology of endophthalmitis. We want to remember, usually it is asked on post-operative cases because that is where we are afraid if we are not maintaining sterility, that is our mistake, right? Now, once we know the etiology, we need to know the presentation or the clinical features, which I hope are pretty easy if we are talking about the symptoms of endophthalmitis. Why it is easy? Because of these words: itis, inflammation. Wherever there is inflammation, as I told you earlier on, there will be pain. Rubor, color, dolor, if you know this, then you know redness. And because all these structures in the eye are affected except the sclera, that means all the visual structures, the retina, the lens, the cornea, then obviously there will be loss of vision. Am I making myself loud and clear here? Once I know this, once I know the history of cataract surgery, I know the patient is presenting with pain, redness, and severe loss of vision, I examine the eye. When I examine the eye, what do I see? I see, starting from the outside to inside, a lot of signs. Based on this image, I will show you the signs. Okay, so let me write signs. First sign: the patient complains of something called as redness. But when the doctor sees redness, the doctor terms the same thing. You can see redness here, everybody. Yes. Congestion. Or the other word used is hyperemia. Am I correct? Secondly, after I've seen the conjunctiva, I see the cornea. Can you see the cornea here? Can you see the cornea is milky white? The cornea is hazy because the cornea is inflamed. As I've been telling you since the beginning of the chapter, since the beginning of the ophthalmology videos rather, yes, that the cornea has to remain transparent, and that is why it is avascular, because vascularity, if there is any infiltration, inflammation occurring in the cornea, there will be loss of transparency or hazy cornea. Thirdly, now from cornea I look inside the anterior chamber. In anterior chamber, as you can see here, what am I seeing here? See, this is the lower limit of your cornea. It's hazy, so obviously you cannot see it clearly in the image. I'm trying to show you to the best of my ability. What do you see collected here? Some whitish material. So there is pus collection in anterior chamber. Pus collection in anterior chamber. Collection of pus in anterior chamber is known as, yes, very good guys, hypopion. Hypopion. Alright, pion means pus. Hypo means which will be in the inferior part of the anterior chamber. Obviously, anything which is present in our chamber due to gravity will go down. So that means we have read two words which are similar to each other, if I can say so. The first word we had read was hyphema. Hy means again down, and phema means blood, yes. And the second word we have just now read is hypopion. Hypo, niche, and pion, inferior. Sorry for the here. Hypo means inferior and pion means pus, collection of pus inferiorly in the anterior chamber. Once I have seen this, I know the anterior segment is infected and inflamed. After this, I should be able to see the lens through the pupil, but I've already done the surgery. If I've done the surgery, that means I already know that there is no lens. I need to see in the posterior segment. That means now I need to look at the vitreous. Obviously, in an anterior segment photograph, you will not to see the vitreous. So usually the image that will be given to you in a question of endophthalmitis will be only an anterior segment image, and along with that will be given a history of cataract surgery, pain, redness, loss of vision, blah blah blah. In the vitreous, please realize vitreous is also transparent. Do you realize this? If you don't realize this, then let me show you, please. Cornea, iris in the center pupil. This is my lens or IUL in this case. Then the vitreous, and then the retina. Okay. Light travels from the cornea. That is why cornea is transparent. Pupil is an empty hole. Lens is transparent. And because light needs to travel the vitreous also, vitreous is also transparent normally. But in case of endophthalmitis, vitreous is inflamed. Okay, the vitreous is inflamed. In inflammation, there are cells and proteins. Cells and proteins forms exudates. So what do you start to see? Yellowish exudates. Alright. Vitreous, you will see some collections of cells and proteins, yellowish exudates, which will tell you that even the posterior segment is involved. That means when I examine the eye, through these signs I know the anterior segment is affected, and through vitreous I know posterior segment is affected. Anterior and posterior both affected, that means the complete eye is affected. I know the symptoms. I know the fact that it is post-operative case, and I know that the sclera has not been affected. Based on all this, I have sufficient information to say it must be a case of endophthalmitis. Now, when I have made my diagnosis clear enough, then the only thing which remains for me is to save the eye if possible by instituting timely treatment. So, what is the treatment? Treatment depends upon the assessment of vision. Meaning what? See, broadly saying, when I see a patient of endophthalmitis, I can have two types of cases. One patient who presents to me promptly, and the other patient who, by the time who came to me, was probably ignorant, I can say, and by the time the patient came to me, the patient was already blind. If the patient presented to me promptly, as soon as he felt some redness, pain, that means the eye would not have ended. That means there would have been some vision present, whatever the vision may be, but the vision is still present or remains. Okay? Now, I have two cases. One is blind, one is with some vision. So first of all, let me ask you, what is blindness? When will I say a patient is blind? When will I say when a patient is blind, when a patient cannot see anything? But what do you mean by cannot see anything? Anybody? Okay. So let me just give you a quick way of or a recap of the knowledge of how we got vision. First of all, we use something called the sentence chart on which the patient reads letters A, B, C, D, S. If the patient is able to read these letters, I know the patient can see. We say 6 by 6, 6 by 60, all those terms. If the patient cannot read sentence chart, then we do something called as finger counting. Then we do hand movements, and then ultimately we show the patient some light. Let's say there's a torch in my hand. I'm switching on the light, switching off, switching on, switching off. Okay. If the patient can see light, the patient cannot see anything, but the patient can see whenever there is some light switched on, that means the patient is not blind. The patient is blind only when there is no perception of light. If you have no idea on how to record vision, if you are probably a student who's just starting out in ophthalmology, then please watch the video on optics where I told you how to record vision and everything. Please watch that. Otherwise, please just understand in one line. If you can see light, you cannot see any object, you cannot read anything, but you can see light. You can see that the light is switched on in a room and switched off. Yes. Then your vision is present. But if you cannot even see light, then you are blind. No perception of light is clinical blindness. Okay? Now, but you understand this. If the patient has gone blind due to endophthalmitis, that means the eye has already ended. What will I think as a doctor? I will think that the eye has lost its function. Its function was vision. And I know there is infection in the eye. The etiology is infected. That infection can spread into the surrounding areas. So does the eye have any use for me? No, obviously not. So I will say let's surgically remove it. When the eye has no use and instead it can cause effects to the surrounding structures, negative effects, what I should do is surgical removal. The surgical removal that we prefer in cases of endophthalmitis is known as evisceration. Evisceration, that's the name of the surgery. Now, if you focus on the English, it's pretty easy, guys. E-viscera. Viscera means organ, E means removal. So that's what we're saying, E-viscera. Remove the organ, E-viscera, and then we are just naming it evisceration. Alright? All these great English, nothing medical science but half English. If you try to understand the English words, then you try to learn everything. That is why the first book we ask you to buy is a medical dictionary, but which we don't use at all. If we use that medical dictionary, it does help us a lot. Yes? E-viscera. Now, what is the definition of evisceration? If you are smart, you already know. See, I will show you the definition of endophthalmitis. The definition of endophthalmitis is suppurative inflammation of all layers except sclera. So what should be evisceration by common sense? Instead of inflammation, I'm just saying removal. The removal of all layers of eyeball except sclera. Are you clear about it? So, see, this is what smartness is. You can remember one thing, and through that one thing, you can probably remember tens of things. It is just how your brain works. Yes. The removal of all layers of eyeball except sclera. That is evisceration. I have clear about this. But what about the second case? What about the case where vision is present? If the vision remains, if the vision is present, that means would I like to remove the eye even now? Or would I like to save the eye because I have visual potential? So I can say the patient's eye has visual potential. If there is visual potential, I will try to save the eye. I know the etiology is infected, so that means I need to give antibiotics. Yes? So what would I give? I will give antibiotics. But where? Do I give oral antibiotics? See, again, think about the local routes of administration. Think about the fact which I just told you, both the segments are affected, anterior segment and posterior segment. What is the best way to give a drug in the posterior segment? Yes, intravitreal antibiotics. Intravitreal antibiotics, intravitreal route of administration has already been explained by, we have seen the sclera and pars sclera, anterior to ora serrata, posterior to limbus, blah, blah, blah. Yes. Now, which antibiotics are preferred? Usually the preferred antibiotics which are given are vancomycin, 1 milligram in 0.1 ml, and along with that ceftazidime 2.25 milligram in 0.1 ml. Okay, based on the usual positive agents. But if you are unsure, then obviously you should take out a vitriol sample and send it for culture. All right. Secondly, this will cover the posterior segment. What about the anterior segment? For anterior segment, the best way to give any drug is topical. Topical antibiotics. Okay. So this will cover the problem of anterior segment. Remember this as a basic concept in ophthalmology. Whenever there is any disease in the posterior segment, the route of drug administration is intravitreal. Whenever there is any problem in anterior segment, the route of administration is topical. So that means if I talk about corneal ulcer, okay, I don't talk to that I, but if I talk to you about corneal ulcer, cornea problem anterior, that means the answer will be topical. But if I talk to you about a disease called as diabetic retinopathy, retina posterior, the answer will be intravitreal. So that is the common sense I will use everywhere. This is basic common sense. Please remember this for ophthalmology. Alright? Now, along with this, the third thing we end up doing is a surgery to clear the vitreal cavity. Pars plana vitrectomy. In short form, we call it PPV, pars plana vitrectomy. Now the question is, why are we doing pars plana vitrectomy? Vitreous is a gel. Gel gives a nidus for the organisms to stick and grow. So we are saying, let us clear the cavity. Let us cut all the vitreous and let us remove it. The point of entry into the vitreous cavity we know is through the pars plana. That is why the name of the surgery has become pars plana vitrectomy. PPV. Done. These are the three important treatment options for, or all the three things need to be done. I write A plus B plus C. Alright. What should not be done? Systemic antibiotics have no role in the treatment of endophthalmitis. It's a local infection. Treat it locally. No need to go global or systemic. Am I making myself loud clear? That's all about the very important acute post-operative complication, which encompasses the late post-operative period also, which is called as endophthalmitis. Now, we are doing acute post-operative complications. I go back to the top. Number one was iris prolapse. Number two is endophthalmitis. Then coming back, number three. The third is, if we are not careful, post-surgery on the next day, we can see a flat anterior chamber or a shallow anterior chamber. If there is some leakage happening, what can be the causes of flat anterior chamber? Obviously, wound leak if my wound is not closed properly. Secondly, it can be due to malignant glaucoma. If you don't know these types of glaucoma, please watch the glaucoma videos. But if you're doing them sequentially, then please wait till we read glaucoma. You will be able to understand all this. Here I'm just giving you a list for your MCQ, you can say. And the third is pupillary glaucoma. And lastly, the answer is cilioporoidal detachment. These are the usual four causes of a flat or shallow anterior chamber. Okay, just remember that in MCQ here. Now, apart from this, what do we expect, or what are the complications which can occur if there has been too much instrumentation during the surgery? It can lead to uveitis. In very rare cases, we can even see retinal detachment post-surgery. And it is very common to see astigmatism, cylindrical refractory error after the surgery. So these are some of the acute post-operative complications, I can say. Though astigmatism is not a complication per se, but we are turning it a complication. Alright, now to end our complication topic, we move on to late post-operative period. Okay, in late post-operative period, the first thing is the most important. We have mentioned this word previously also, PCO. What is the full form of PCO? Posterior capsular opacification. Posterior capsular opacification, PCO. Forget everything, but never forget this word, because you are going to see it a lot if you are an ophthalmologist. I will not say every day, but a lot, yes. PCO is also known as secondary cataract, and by some authors, after cataract. But as I will explain it to you, both these are misnomers. Both these are misnomers. What do I mean to say when I say misnomers? Misnomers means they are giving you the wrong information. These two words, secondary cataract and after cataract, are trying to tell you that they are types of cataract. But I am saying no, I beg to differ here. They are not types of cataract. Cataract can only occur once. Just like if you have seen a movie called Kuch Kuch Hota Hai, Shahrukh Khan, the actor, says, जीवन में प्यार भी एक बार होता है और शादी भी एक बार होती है, right? Bad joke. Again I'm saying I'm the king of pigeons. So I say cataract can also occur only once. Once I have done the surgery for cataract, I have taken out the cortex and the nucleus. There is no fundamental of cataract occurring there. But it just looks like a cataract, it presents like a cataract, that is why it is a cataract. But what is actually the name? The actual name is PCO, posterior capsular opacification. Now, let us see what is posterior capsular opacification through these images. This is my IOL, this is my capsule. The capsule, you can see this is the anterior capsule and this is the posterior capsule. And in the center, we have created a CCC. Okay, now, even after we have cleared all the cortex or in the nucleus, you can see there are some residual epithelial cells which get stuck, which remain stuck. Residual epithelial cells. It is impossible to absolutely clear out the epithelial cells. So what happens? These residual epithelial cells slowly, they migrate posteriorly. Can you see? They are migrating posteriorly. When they migrate posteriorly, they go behind the lens. All this, concentrate on this area. They go behind the lens, guys, and behind the lens, they form collections in the form of opacities. And that is why we say posterior capsular opacity. Now, once posterior capsular opacity has occurred, the light which is going in will get blocked by the posterior capsular opacity, and that is why it will lead to loss of vision. Alright? So, posterior capsular opacity causes gradual, painless loss of vision. Now, as soon as I say this, does cataract?
Yes,
Do you hear cataract, gradual painless loss of vision? Yes. So that's why we are misnumering it as cataract because it is presenting like a cataract. Because it causes gradual painless loss of vision. Please remember, guys, it is the most common late complication. This usually presents 6 to 12 months after surgery. Usually, I am saying, not always. Sometimes it can present later on also, much later on, but usually present 6 to 12 months after surgery. It is of two types. The first is called as L-shaped pearls, pearl-shaped deposits. And the second is called as Sommer-Rings ring. L-shaped pearls and Sommer-Rings ring. 90% cases are pearl-shaped deposits, only 10% cases are Sommer-Rings ring, and that is obviously the more common is L-shaped pearls. Why do L-shaped pearls occur? This is what I had explained to you here, because of, if I can, because of posterior migration and collection of residual epithelial cells. Okay, that is why pearl-shaped deposits are there. Alright, as I told you earlier on square-edged, the square-edged IOLs, they reduce this migration. So because they stop this migration, round edge will allow this square edge probably creates a barrier. That is why they have reduced the occurrence of PCO, but nonetheless they still occur. Now, if it is occurring, what is the treatment? That is the question which now remains. So let me draw a diagrammatic representation for you, just like we have drawn earlier. This is where my IOL is present. Yes. Now, I have an opacity. As we just now saw, I have an opacity on the posterior capsule. Now, realize our main part of vision is through the center. Periphery we are using only during the night. The majority of the day we are using only the center. Okay? So the main vision we need clear is central vision. So now we need to clear this opacity. One way is to go and do the surgery again to clear it. But see, surgery is intraocular. So every time you are doing an incision, you are going inside, you are creating chances of endophthalmitis, post-operative infection, which you don't want. So ideally, you want a surgery which does not open the eye. That means which word you are tilting towards, yes. But as you know, this is not the word which I am happy with, yes. So you need to know a little bit more. What are you doing with the laser? Which laser are you using? First of all, what are you doing with the laser? You need to clear this. To clear this, I say, let us do the same thing that we did for the anterior capsule. Let us create a hole in the anterior capsule in the center. This hole is obviously much smaller than the lens, so the lens will not be able to fall down. It will have support in the periphery. Can you imagine it? Can you understand it? Yes. Now, which laser do we use? ND-YAG, neodymium, yttrium, aluminium, garnet. Okay? ND-YAG laser is cutting the posterior capsule or creating a hole in the posterior capsule known as posterior capsulotomy. Alright? Now the name of the laser is ND-YAG, you understand? How does ND-YAG laser act? What is the mechanism of action? I just now told you creating a hole. That means it is cutting or disrupting or breaking. So just like ND glass, this is also photo disruption. Posterior capsulotomy, you understand, hole in posterior capsule. If you can try to remember, please do. Wherever we need to create a hole in any structure, we have to use NDR laser. Alright. In cataract, we don't need to create a hole, we need to actually break it into small pieces. That's why we're using a better laser, femtosecond laser, ND glass laser, and not ND yarn laser. I hope we are pretty clear about this. Yes, now. To complete our knowledge on PCO, let us see the two images on the screen. First image and second image. In the first image, you can see the IOL. First of all, can you see the IOL? Yes, can you see the nice IOL? And behind the IOL, can you see pearl-shaped deposit? That means what you can see. You can see Elschnig pearl PCO. I just checked the spelling, sorry for writing it wrong. Elschnig pearl PCO. Okay, now, in the second case, what you can see laser has been done. And see, this is the margin of the IOL. I'll just draw it with another color. You can see this is the margin of the IOL. Okay, so you can see a faint IOL shadow. And along with that, you can see, I'm drawing with green color, see, this is a central opening which has been created. In the periphery, you can still see lot of pearls. So this is ND YAG laser posterior capsulotomy done. Okay, so you can see both the photographs. Now you can see the center is absolutely clear, so there will be no compromise in the vision, guys, right? And that's all about our main important complication, which is the late postoperative complication, and which is called as PCO, not cataract. Once we're done with this, let us move on to the second complication, which is a late postoperative complication. The photograph is visible. I'll write the name for this. This is called as anterior capsular phimosis. Anterior capsular phimosis. Now, again, this also occurs due to the post-operative inflammation, I can say. Okay, when there is inflammation, there is fibrosis. It leads to fibrosis. So, what occurs due to continuous fibrosis of the anterior capsule? Anterior capsule, as you would be able to see in the image, there is the anterior capsule is completely fibrosed. Fibrosis leads to contracture. Contracture means it is pulling everything in, yes, and that leads to IOL decentration. The IOL, which should have been positioned in the center, because of the contracture, forces are applied on the IOL, that has been moved slightly up, slightly down, left or right, so it leads to IOL decentration. That is why when we are doing cataract surgery, when we are doing irrigation and aspiration, we want to make sure to clear as much of the residue as possible. Alright, as you have seen in the surgery, polishing was being done, everything was being done during the cataract surgery. Okay. Now, apart from this, what other complication can occur in the late postoperative period? There is something called as the Irwin-Gass syndrome. Irwin-Gass syndrome, this usually occurs 6 to 10 weeks after surgery. It is a triad. A triad means three features are seen in Irwin-Gass syndrome. The three features are: number one, cystoid macular edema. Retinal edema, macula is a part of retina, yes. CME. Along with that, bullous keratopathy. Cornea as bulle. Bulle means swelling, small swelling seen all over the cornea. Bulle, cystic spaces. And third is vitreous strand touching cornea, also called as the vitreous wick. Okay, it looks like a wick, it looks like the projection of a diabati, yes, which is coming from behind and touching the cornea. Alright, and due to this vitreous touch, the swelling is occurring from the anterior to the posterior segment, because this is acting as a route for the gel and the fluid to mix slightly, and thus causing retinal as well as macular edema, and that is called as vitreous wick syndrome by somebody, but the main common name used is Irwin-Gass syndrome. I hope I'm pretty clear here. If we understand this, then the last, the simplest complication that I think you would know is IOL dislocation. Now, I don't think that this is asked these days a lot. This is too basic information, but yes, it can be asked, especially in the vivas of my pre-final year students, for people who know the basics at least, yes. If the IOL dislocates upwards, which can be due to any reason, we have discussed a lot of reasons, yes. If you are able to extrapolate, IOL dislocates upwards. This is known as sunrise syndrome. Second, if the IOL dislocates downwards, okay, Obviously, it will be known as sunset syndrome. Not too much to explain. I can't harp on about it. And lastly, this you will be able to think about. IOL is lost. IOL is lost, or I will say IOL falls in vitreous. IOL is not seen in the pupillary area. Complete dislocation. This is called as lost lens syndrome. Okay? Now, if you can understand lost lens syndrome, IOL falls into the vitreous. IOL is not seen into the pupillary area. If the IOL is completely dislocated, I will not be able to see it at all. Why does lost lens syndrome occur? Anybody? Think about it. We have read something already. We have read the main important thing, PCR, operative complication, in which what is occurring, IOL is falling down. Yes? So PCR is basically leading to what? PCR is basically leading to lost lens syndrome. Or in certain cases, long after the surgery, it can be spontaneous. When it is spontaneous, it is known as Hallermann-Streiff syndrome. Hallermann-Streiff syndrome. Alright. Recently, I have had the opportunity, recently means in the past 1.5 months or so, I had the opportunity to see 2 cases of Hallermann-Streiff syndrome, where the patients reported, gave me history of cataract surgery. One was, I think, 12 years back and one was 20 years back. And then they reported to me saying we have lost our vision completely. When I examined it, I saw that the lens was, or the IOL was nowhere to be seen. And when I did the examination, when I did ophthalmoscopy and everything, I found out that the IOL had completely dislocated into the vitreous cavity. Then when I asked them what occurred, did you have any vision? They said yes, for the past 20 or 12 years, we had complete vision, but only in the past 1 or 2 months we think that we have lost our vision. Yes. Did they have any history of trauma? No, as far as the history was concerned. Did they have any other specific systemic history? No. So that means my diagnosis in both those cases was spontaneous, complete dislocation of lens, Hallermann-Streiff syndrome. Alright, guys, done. So this is our total complications. We have read 3 groups of complications, if you can understand now: operative complications, acute post-operative, and late post-operative. If I can summarize that for you, in operative complications, PCR is a very important complication. In acute post-operative period, please remember end ophthalmitis as one very important complication. And in late post-operative period, please remember posterior capsular opacification at least. At least these are very, 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 very important complications. Everything is important, but these are the most star important, guys. Alright? And that ends my topic on acquired cataract. Yes, this is what acquired cataract is. This is the main pathology which we have been studying. Yes? All the types of cataract acquired, all the treatment, everything could be done with the treatment. That means now we can start with our second type of cataract, which is congenital cataract. Congenital cataract. Congenital cataract, as we had read earlier, can be divided into two main groups. The first name is infantile cataract. Some people also call this as primary congenital cataract. And the second name is developmental cataract. This I told you before, that the main point of distinction between the two is that the age of presentation in infantile cataract is within 1 year, whereas in developmental cataract it is after 1 year. I think the name infantile is self-explanatory to remember this. Yes, because it is infantile, it is presenting in the infant age group which is within 1 year, but developmental is presenting after 1 year. Now the challenge sometimes students face is when they are revising it or reading it and trying to understand it. Congenital means present since birth. Yes or no? But developmental, I am saying age of presentation is after 1 year. If the age of presentation is after 1 year, isn't it acquired? Isn't it occurring after birth? See again, that's why I mentioned age of presentation, not the age of onset. Congenital means the age of onset is at birth, not the age of presentation. The disease onset may be at birth, which is not visible clinically. Age of presentation means when it becomes visible clinically. So the distinction is based on the age of presentation, not the age of onset. Age of onset in both the groups is at birth, that is why both the groups are congenital. Now, acquired cataracts, we studied that they are progressive, they increase gradually. Congenital cataracts differ from the acquired cataracts in the fact that they are so slowly progressive that we start calling them almost, you can say, I'm writing here in the between both of them, that they are almost stationary. They are so slowly progressive that they don't progress at all. Yes? So that's a very basic difference. The question which comes into my mind is, what is the need to divide congenital cataract into two groups, infantile and developmental? Infantile cataract, because it presents within 1 year, we see it causes severe loss of vision. Why severe loss of vision? As it interferes with foveal fixation. Now, what do you understand by this word, foveal fixation? See, we know through our anatomy that fovea is the most sensitive part of the retina, in the fact that maximum concentration of cones is there. So our eyes are positioned in such a way that the visual axis is from the object onto my fovea. So that whenever I'm seeing straight, my vision is being formed at the best part of my retina. But how does our brain get to know that the best part of the retina is fovea? Brain is like a computer, guys. Brain functions on data. So when you are born, when you open your eyes regularly, light falls onto each part of retina. Yes. When light has fallen onto each part of retina, the brain has the data from all the points on retina. And then the brain is able to realize that the best image formation is at the fovea. And then your eye position gets fixed. Alright. This foveal fixation usually occurs by 3 to 4 months of age. So if you have infantile cataract, that means it can interfere with foveal fixation. That means your brain will never have the correct data. Your brain will never be able to assess that fovea is the best point of vision. So if your vision is not occurring or if your image is not forming at the fovea, you will never have the best vision. So in entirety, if I say this foveal fixation funda, if the foveal fixation does not develop, it can lead to sensory deprivation, amblyopia, loss of vision. Yes, without any organic cause. Without any organic cause, even though that there is cataract, but the cataract itself is not causing loss of vision. The loss of vision is due to non-development. Yes, the brain has not been able to foveal, has not been able to do foveal fixation. Do you understand this? Yes or no? Compared to developmental cataract, it has minimal loss of vision. Because the loss of vision will be directly proportional to the amount of opacity, there will be no fundamental of foveal fixation, no fundamental of amblyopia. So because of this important point that infantile cataract causes severe loss of vision, we need to differentiate these groups, because at the end, if I have severe loss of vision, imagine, if I expect severe loss of vision, if I expect amblyopia in a patient of infantile cataract in an infant, then I need to do surgery immediately upon diagnosis. Okay? Till around 12 weeks of age. Because if I don't remove the cataract before that, foveal fixation will never be able to occur. Okay? But if we are talking about developmental cataract, where the loss of vision is minimal, we can wait and watch. Do you understand this basic difference, clinical difference, based on one simple point, that is the age of presentation when the cataract is there? All right. Now, once you understand this, everybody, let us see the most common types of both the cataracts. So, what is the most common type of infantile cataract? The most common type of infantile cataract is called as lamellar cataract, which is also called as or known as zonular cataract. Lamellar or zonular cataract. Whereas the most common type of developmental cataract is called as or known as blue dot cataract. I'm smiling because whenever I hear the name blue dot cataract, I get taken back to pathology. In pathology, we used to study something called as Down syndrome. Yes, blue dot syndrome is associated with Down syndrome. We used to study it in our pathology book knowledge or whatever you are studying these days, right, guys? Done. Now, lamellar or zonular cataract, on the other hand, is found to be associated with number one, congenital rubella syndrome. Number two, it is found to be associated with vitamin D deficiency. And number three, it can be inherited in autosomal dominant inheritance pattern. Alright, so these are three associations of lamellar or zonular cataract. I'll just draw a line in between them. Now, lamellar or zonular cataract, clinical feature or presentation. I will draw a diagram, and through that diagram I'll try to explain the clinical features of the presentation. If this is my pupillary area through which the lens is visible. The main opacity is in the center. In the center means where is it, guys? Is it in the nucleus or is it in the cortex? Yes, obviously, sir, it is in the nucleus. Along with this, what I am drawing with red color, there are spoke-like opacities, some small opacities, some large opacities, but they look like a bicycle wheel, spoke-like appearance. That is why we say there are two clinical features. The clinical features are main opacity seen in fetal nucleus. See the opacity seen in fetal nucleus, that is giving you a clue. What is it giving you the clue? That the onset of cataract was when the fetal nucleus developed, when you were a fetus. So obviously in utero, congenital, yes. Along with that, these spoke-like opacities, spoke-like opacities are seen, which are known as riders, Alright, everybody. And that's your lamellar or zonular cataract. I will also show you an actual photograph of this. If you see this photograph on the left side of the screen, if you see this photograph, you will be able to see the same thing, that this is my iris, this is my pupillary area. In the pupillary area, the periphery is clear, the center has an opacity, and you can see some spoke-like opacities. I will draw them for you. 1, 2, 3, 4. 4 large spokes are visible if you see carefully. I'll rub them again, you can see this. Alright, so this is a case of lamellar or zonular cataract. Clear? Done? Now, let us move back to developmental cataract. In developmental cataract, we have read that the most common type is blue dot. Apart from blue dot, there is another important type of developmental cataract, which is called as posterior polar cataract. Now, as soon as I have written the name posterior polar, where do you think the cataract is? At which part of the lens? Posterior pole, where the capsule is thinnest? Yes. Posterior polar cataract has a classic appearance which is called as the onion ring appearance, also called as the whorled appearance. Onion ring appearance, also called as the whorled appearance. Onion ring, if you are cutting onion, if you are seeing it, yes, you will be able to see some rings in it, or if you see a whorl, it is shaped like this support. So this is the kind of appearance that you have on a posterior polar cataract. Okay, it's pretty easy to recognize once you get this in your head. Let's see this image. First of all, I will see the slit beam illumination. Slit is being thrown from this side. This is my cornea. This is my anterior chamber. This is my lens. Can you see the lens? Anterior capsule. Then the whole lens. And then if you see, the opacity is shining on which slit or on which level, the opacity is shining on posterior capsule. That is giving me an indication that the opacity is on the posterior pole, the center of the posterior capsule. And then I see the shape, and then it looks to me like a whorl or an onion ring, and that is why I know for sure that I must be talking about posterior polar cataract without any doubt. As I told you, this oblique beam, slit lamp illumination will keep on coming handy to you, so please try to focus on this. Alright? Now, posterior polar cataract is found to be associated with Mittendorf dots. If you remember the anatomy of the lens, we have discussed Mittendorf dots. There is a rudimentary, there is a canal which is present during embryogenesis which gets absorbed, known as Cloquet canal, which provides the site for hyaloid artery. Yes. So what is Mittendorf dot? Remnants of hyaloid artery. Sometimes also written in the question as tunica vesiculosa lentis, blood vessel to the lens. Hyaloid artery supplying blood vessel to the lens. Yes. The second association is with something called as PHPV. The full form is persistent hyperplastic primary vitreous. This is a pathology that has something to do with vitreous or retina. We will discuss in the chapter retina here. Just remember that this is also an embryological entity which can lead to posterior polar cataract. Alright, so we have done the types of cataract, the two types of cataract which are infantile and developmental. The main difference with the type of loss of vision, depending on which there is that timing of surgery. In infantile, because there is severe loss of vision, it is done immediately upon diagnosis by around 12 weeks of age. Then the most common is lamellar or zonular, and the most common of developmental is blue dot, along with that one more important developmental cataract which is posterior polar cataract. Now, I want you to focus on congenital rubella syndrome. You all of us read the Dodge infections in pediatrics in medicine everywhere. Yes. Why am I telling you is, I have told you lamellar cataract is associated with congenital rubella syndrome. The question which is asked is, what is the most common cataract in congenital rubella syndrome? I have not said that congenital rubella syndrome most common cataract is lamellar. I am saying it the other way around, that lamellar can occur in congenital rubella syndrome. But students keep on confusing this and getting this question wrong. That's why I'm just writing this for you here, congenital rubella syndrome. Very brief. Congenital rubella syndrome, when does it occur? It usually occurs in the first trimester. The most chances are in the first trimester of pregnancy. Yes. Now, ocular, most common cataract which can occur is called as nuclear pearly cataract. Please remember this. Along with that, you will have microphthalmos, and you find salt and pepper retinopathy. I hope I'm pretty clear here. Yes, these are the three common manifestations that we can see in a case of congenital rubella syndrome. The most common cataract I clearly listed cataract is associated, but it is not the most. Clear? Done. What under which? Now, let's move back to congenital cataract. We've studied the types of cataract. Now, if I ask you what is the treatment of congenital cataract? So obviously, the treatment of congenital cataract is again surgery. Obviously, yes, obviously surgery. But which surgery is my question? Again, the answer is simple. The answer is ECCE surgery plus IOL implantation. Okay? Do you understand? The basics remain the same. But what is the difference from the normal surgery that we do in adults? That is what I'm trying to explain to you. Instead of lens breaking, we can do lens aspiration. Instead of breaking the lens into small pieces like we were doing in frequent emulsification or like we do in other surgeries, the lens here is very soft, the lens is not hard at all. So we can simply suck it out. Alright, we don't need to perform nuclear fragmentation. No. Yes. What is the most common layer complication of ECC based cataract surgeries? PCO, posterior capsular opacification. When we are doing it in an infant or in a child, we know PCO is going to occur. It is going to occur because the child has the whole life to live. It is going to occur. And when it occurs, I will have to do laser. Laser comes with its own side effects because of dissipation of energy to the surrounding structures. So when I already know it is going to occur and it is going to trouble a patient, remember, in adults, the adult may not even complain of it, but by the time the adult starts having problem, he would have already passed away because of the ages. But a child has to live 70 years, 60 years of his whole life still. So when I know that PCO is going to occur, during the surgery only, I perform posterior capsulorhexis. You understand this? Am I making myself loud and clear? Yes? But I know, just like I perform anterior capsulorhexis, CCC, if I perform posterior capsulorhexis, vitreous will start mixing with the aqueous. Yes? I know that, so I'm already prepared. And during the surgery only, we do anterior vitrectomy. Alright? Lastly, obviously we need to implant an IOL. But what is the difference? IUL implantation is usually done after 2 years of age. I'm saying usually. See the word, I'm saying usually. So these are the differences. First of all, we aspirate the lens, then we, to prevent PCO, or because we know it is going to occur, we do posterior capsulorhexis, then because of posterior capsulorhexis, vitreous will come, so we do anterior vitrectomy, and then we need to choose the age when to implant an IUL. So the question from my mind is, why are we not implanting an IUL in an infant's eye? Let's say the infant is 6 months of age. Let us understand. The normal axial length is 24 mm. When the child is born, is the eye the same size as the adult eye? No. When the child is born at birth, I will say, the axial length is around 17 mm. That means the eyeball is small. That means from birth, the eyeball is going to enlarge. And axial length becomes 24 at around 7 years of age. Okay? So because we know the eyeball is going to enlarge, so we know the space for the lens is going to increase. That means if I need to implant an IUL at birth or within the first year of life, I need to choose a smaller IUL. Now let's say I implanted a smaller IUL. When the IUL will become enlarged, this IUL will become loose and it will lead to dislocation of IUL. Yes? Secondly, at birth, because of small axial length, child has 2 to 3 diopter of hypermetropia. As the eyeball enlarges, the power of eye increases. That means, because the power of the eye is going to increase, I need to choose an appropriate power which does not create a problem later on, such that I don't need to give spectacles. So, power of IOL. Okay. If age less than 2 years, biometry value, biometry power minus 20%. But if age is between 2 to 8 years, then biometry power minus 10%. So that means we basically undercorrect. Because we know the eye power is going to increase. Because the eye power is going to increase, the IUL has to be implanted of lesser power to factor into that. So we undercorrect. Am I making myself very clear, loud and clear here? And that is all about the treatment of congenital cataract and a little bit of understanding which you need to have as far as the differences are concerned. Now, that's all about our topic on cataract eyes, the main disease in lens. We have read the anatomy of the lens, the biochemistry of the lens, and the main disease cataract. Does that finish our chapter lens? Yes, it should, but there are some small topics. So I can divide lens into 3 topics. One is the anatomy and the biochemistry, the basics. Then the second is the main topic, cataract, and everything related to it. And then third are other diseases. So in other diseases of the lens, when we start to study, the first disease is the most important occurrence is ectopia lentis. Now, again, if you know your medical English, you know lentis means lens. Ectopia means ectopic, ectopic, yes, away from its position. So I can say ectopia lentis basically means displacement of lens. Now this displacement of lens can either be partial dislocation or it can be complete dislocation. When it is partially dislocated, we refer to it by the name subluxation of lens. Okay, am I clear? So basically ectopia lentis and subluxation of lens are synonyms for us. Yes? Now, let us see this image on the screen. In this image, if I ask you to identify what is the pathology visible, what will you say, everybody? Yes? Yes. This is my light color, you can see. So this is the iris. Pupil has been dilated. Now, when pupil has been dilated, normally we should be able to see a complete lens. But here, what do we see? Do we see any lens at all in this area, guys? No. If you see carefully, this is the margin of the lens. Lens is present in this area, but there is no lens in this area. That means what can you see in this? In this image, you can see inferior dislocation of lens. Yes, ectopia lentis or subluxation of lens. Am I making myself very clear? So that is a simple photograph. I will just rub the markings for you so that you can see it again. This is what you can see. This is how you diagnose ectopia lentis. Just by looking at it, you can see the lens falling down or wherever. Now, Once we know the image, once we are able to diagnose it, everybody, let us see the causes. Most common cause. What is the most common cause of ectopia, guys? If you are saying Marfan syndrome, you are absolutely wrong. Yes, you are wrong, guys. You are wrong. Usually we think it is Marfan syndrome, but Marfan syndrome is the most common cause when we are talking about a systemic association. Overall, most common cause is not Marfan syndrome, it is blunt trauma. Blunt trauma to the eye. Due to the excessive force, the zonules will break and then the lens will become dislocated. Secondly, we know it can be familial, means it can be inherited. When it is inherited, it is autosomal dominant. Thirdly, the condition is called as ectopia lentis et pupillae. Ectopia lentis et pupillae. So this is a little bit of French for you. Lesson in French. Ectopia lentis means dislocation of lens. Et means and. Pupillae means pupil. So this is a congenital bilateral condition. That's what you need to understand, in which both the pupil and the lens are dislocated. They move in opposite directions. Meaning, if I can draw, I don't know. Let me see. This is my cornea. This is my pupil. Okay. And behind the pupil is my lens completely. But here, what is going to occur? If this is my cornea, my pupil will be here, and this will be my lens. So if I can draw it in a better way, this will be my lens. This is my iris. Okay. So what do we see in this? That the pupil has moved up, but we can see that the lens has moved down. Bilateral condition where pupil and lens move in the opposite directions. That is what the meaning of ectopia lentis et pupillae is. Apart from this, it can be associated with aniridia, that is the absence of iris. Now I say Marfan's syndrome. Okay. Marfan's syndrome. Marfan syndrome is the most common systemic association for ectopia lentis. Most common systemic association. In Marfan syndrome, they ask you a question. What is the question? They ask you, what is the direction of ectopia lentis? When they ask you this question, look at this word, fan. Fan. So as soon as you hear a fan, I think about where is the fan located? Is the fan located inferiorly or superiorly? Superiorly. So that means the direction of my lens is super. Now when a fan rotates, where does the air go? Does the air go only nasally in the center, or the air goes throughout all the four ways temporally? Where does the fan throw air? Only below it or all around it? All around it. That means I can say temporal. That's how I remember. A fan is situated superiorly and throws air temporally all the way around it. So that is why I say supratemporal ectopia lentis. Along with supratemporal ectopia lentis, you will also see cornea plana. Plana means cornea is curved, no, cornea is flatter, and it is larger, megalocornea. Because cornea is larger, it is flatter. The smaller the cornea, the smaller the cornea, the more curved it has to be. The larger the cornea, it will become flatter. Obviously, the larger the circle, the lesser the circumference. If you can understand a little bit of physics, yes, the radius of curvature decreases if the curvature increases that way. Then, we see lattice degeneration of retina. Because the eyeball becomes longer, we see axial myopia. Both these are due to increased axial length of eye. Just like the patient becomes tall, the extremities become longer, we see these things, lattice degeneration of retina and axial myopia as well. Now, also remember, you can see dilator pupillae hypoplasia. Alright guys, done. That is about Marfan syndrome. Now we move on to the next cause. We are doing the list for ectopia lentis. The next cause is another important condition on which questions are asked commonly, homocystinuria. Homocystinuria. What occurs in homocystinuria? In homocystinuria, there is deficiency of cysteine. When there is deficiency of cysteine, it leads to accumulation of homocysteine. And due to this accumulation of homocysteine, and obviously methionine also along with it, there is zonular disintegration. And zonular disintegration leads to ectopia lentis. Alright, so you understand the cause? But again, the question that the examiners ask you is, what is the direction of ectopia lentis? Again, I ask you to look at the name, homocystinuria. Because of accumulation of homocysteine, it is excreted in the urine, homocystinuria. So from urea, I understand urine, it is a very bad way to remember, but you will be able to remember. Where do you pass urine, superiorly or inferiorly? Now, when you pass urine, does it go centrally or all around? Obviously, yes. So inferonasal. I know a lot of you said all around, but no, it is central. Yes, ectopia lentis is inferonasal. That's how we remember it. Please, to diagnose homocystinuria, biochemistry you must have studied it. We can detect it by the cyanide nitroprusside test. Just an accessory piece of information which I remember to correlate your basic subject. Diagnosis is done by sodium nitroprusside test. Now, next cause is a condition known as Will-Marchesani syndrome. Will-Marchesani syndrome. Now, in this they ask you the direction of ectopia lentis. I again look at the name and I zero down on the word March. I'm not talking about the month March, January, February, March, April. No. I'm talking about the English word March, which is used in army. What are the Jawans called in the army soldiers? They are said march forward. That's how I remember it. I have to march forward. So I say forward. Forward in medical language becomes anterior. So I have a forward or an anterior ectopia lentis. Are we clear about this? Along with that, please remember that all these patients of Weil-Marchesani syndrome, they have short stature. This is sometimes used in the questions, and they have small, stubby fingers. Stubby fingers, small and thick fingers, right? Small, stubby fingers. So these are the three diseases in which they ask you the direction of ectopia lentis, which you can remember as fan. Fan is up and out. Urine is down, infro and central, and march forward or anterior ectopia lentis. Yes. Now, apart from these three important causes, they ask you the list all of the following are found, or all the following cause ectopia lentis except. So you should know some other causes. The other cause is sulfide oxidase deficiency, hyperlysinemia, and even it can be seen in Ehlers-Danlos syndrome. Ehlers-Danlos syndrome. Am I making myself very clear? So these are all the important causes of a case of ectopia lentis. Now, once we know the causes, what we should know are the clinical features. What does the patient complain? If you have been watching the videos carefully, then you already know the answer. Look at the image again. When I look at this image, what do I see? I see plus 16 diopter power inferiorly. But I don't see any power here. That means what? That means if I draw a ray diagram for you, if this is my pupil, and now the lens has dislocated inferiorly, right? So the light rays which are going from the inferior portion, they are converging onto the retina. But the light rays which are going in the superior part of the pupil, they are not converging. That means what? How many images will be formed at the retina? How many images are getting formed at the retina? One clear image? Yes, but one image is blur image because it is not getting converged. So that means the patient will have, yes, very good. The patient complains of diplopia, but which type of diplopia? If you can correlate the squint video where I discussed the cause of monoocular diplopia and binocular diplopia. So the cause is in one eye. As soon as I close the eye, my diplopia will disappear. All right. How do I diagnose it, or what are the signs I see, or what is the sign I see? So we simply say on examination, golden reddish crescent is seen in the pupillary area. Golden reddish crescent. Crescent means like a moon. Everybody, let's see this. Again, I'm using the same image. If I can show you through this area is distinctively more redder than the inferior area. So we are calling this area a golden red crescent. Okay? But normally we should not be able to see two distinct colored areas in the pupil, but here we are able to see, and that is the diagnostic point. Now if you can see this, I will rub it for you again. See the golden reddish crescent looks like a moon. Forget it is a eye, you will be able to see a moon here. Right, guys? Am I making myself very clear? And that is all about ectopia lentis. What should be the treatment? If it is only partial dislocation, then you can help the patient with a pair of glasses. But if the dislocation is like this, where diplopia will always trouble the patient, then there is no other option but to refixate the lens or to perform a surgery like ICC or ECC. It depends on a lot of factors, like I told you, how much is the zonular disintegration, what is the cause, and everything else. But basically, only two options are possible: either spectacles or surgical. Remove the lens and implant an intraocular lens, any special type of intraocular lens in the ACIOL, in the sulcus, or wherever. Right, guys? Are you clear about this? And that's all about our first accessory topic, that is ectopia lentis. Now we move on to a second accessory topic, which is lenticonus. So again, these two words, lenti means lens, and conus. Conus obviously means cone shaped. So now my lens has become cone shaped. The normal shape of my lens is biconvex. Yes. Now, if you remember, there are two surfaces in the lens, anterior surface and posterior surface. That means I can have two types of lenticonus. Anterior lenticonus, everybody, or posterior lenticonus. Okay, let us see the photographs. These are slit beam photographs. Photograph A. If I look at photograph A, slit is being thrown from the left side. First of all, this is the slit of the cornea. This is the slit of the cornea. Then this is my anterior chamber, or my aqueous, posterior chamber, anterior chamber, because the pupil is dilated, I don't know. Then if I see the lens, the posterior surface is convex, but the anterior surface is clearly cone shaped. It should have been convex, but it has clearly become cone shaped, telling me that it is a case of anterior lenticonus. Now when I see the second image, I see again the anterior is absolutely convex, but the posterior now has become cone shaped. Without any doubt, a case of posterior lenticonus. Okay, I'll rub all these markings for you so that you can see them again. Anterior lenticonus, posterior lenticonus. Once we know anterior and posterior lenticonus, all we need to know are the causes for them. So what are the causes? The causes for anterior lenticonus can be remembered through the mnemonic. The mnemonic is SAW. S for spina bifida, A for Alport syndrome. Alport syndrome, obviously, I hope you have heard this because it causes sensory neural hearing loss, plus there is abnormal glomerular basement membrane. Yes? So we read it in nephrology, in pediatrics, basement membrane. And W for Waardenburg syndrome. But when we are talking about posterior lenticonus, we have one cause, that is Lowy syndrome, also known as the oculorenal syndrome. In this, obviously, we find posterior lenticonus. Along with that, we find congenital cataract. Along with that, we find congenital glaucoma. And we also find microphakia. The lens has become smaller. Lowy syndrome has X-linked inheritance. Okay, and that's all about my topic, lenticonus. Two images and some causes which you can remember, I hope, without any confusion. Last topic, in lens, that we need to finish lens with, microspherophakia. Now, as soon as I say microspherophakia, micro means small, sphero means spherical, and obviously phakia means lens. So this is a congenital. If you don't understand, I'm writing, nothing is causing it. This is a congenital defect. This is a congenital defect which is causing a small and a spherical lens. The lens has become small and spherical. Because the lens has become small, that means the radius has become smaller. The lens curvature has increased. And due to lens curvature increase, there is myopia. The power has increased. Alright. Then the lens has become spherical. Because the lens has become spherical, there are chances of dislocation, which leads to secondary angle closure glaucoma. Alright, so if you ask me what are the clinical features of microspherophakia, these are what we'll say. It can lead to secondary angle closure glaucoma and it can lead to myopia. I hope I'm pretty clear about microspherophakia. Where does microspherophakia occur? It occurs in Marfan syndrome. It occurs in Weed-Marchesani syndrome. Okay, so usually the causes of ectopia and the causes of microspherophakia are somewhere the same. Done, everybody? Very rarely asked topic. Yes, that's all about our lens topic. Again, I will say in lens we have to read three parts. Number one is the anatomy and the biochemistry. Number two is cataract, and number three are other disorders. Remember, in cataract there are two types of cataract, that is acquired cataract and congenital cataract. Acquired cataract is of four types: metabolic, traumatic, complicated, senile, and congenital is of two types. What are the two types? Number one, infantile. Number two, developmental. Remember, in surgery we do not remove the capsule. We take out the lens, except the capsule, by creating a window in the anterior capsule, and then we implant an IO. This is a very, very, very basic framework, 1 minute framework of lens. If you understand this, if you remember this, then there are chances that when you revise, you do not forget it. See, that's the basic problem that students tend to have. Students say that even though we have read it, we have forgotten it. When I read ophthalmology for the first time, I also didn't remember it. When I read it for the second time, I thought, oh, now I remember something. Then I read it again, then I read it again. By the time I had probably revised it for the fifth time, my fifth reading, each reading, number one, becomes quicker. And number two, in each reading, you get more confidence. So if you read only a topic for the first time, don't get disheartened. That is what revision means. The more you read, the more and more number of times you are able to read a topic, whether that is in the form of a theory or in an MCQ, you are going to do that. Disheartened mind does not flourish. Yes, if your mind thinks you are not good enough, you will never be able to do it. You are good enough. You are the best. Please. Now let's begin with the anatomy of the middle layer. Yes. So middle layer is known as uvea colorati. We know it is the vascular layer, and we know what is written in the screen. It has three parts. Number one, iris. Number two, ciliary body, and number three, choroid. Ciliary body is further divided into two parts: pars plicatum and pars plana. This much you already know. Now, what new am I trying to tell you? When we read the parts of uvea, it feels as if iris is anterior, ciliary body is intermediate or middle, and choroid is posterior. But when we are clinically studying it, that is not the case. When we are critically studying it, iris and pars plicatum, they function together, and thus they are known as anterior portions of uvea. Ciliary body pars plana, alone pars plana, is termed as the intermediate part of uvea. And lastly, choroid, obviously, this remains the intermediate uveitis and posterior uveitis of. See, pupil is not a structure, pupil is just an it's there, which gives the color. I have brown colored iris. So how does it help us? It helps us when we study a uvea chapter. In uvea, there will be three types of uveitis: anterior uveitis, intermediate uveitis, and posterior uveitis, obviously. So when we will be saying anterior uveitis, we will not be saying inflammation of iris alone. We will be saying inflammation of iris along with that pars plicatum. And when we are saying intermediate uveitis, it will be inflammation of pars plana, and posterior will be simply inflammation of choroid. Alright. So you can say the anatomical nomenclature and the functional nomenclature both are written together for you to see. Now we will pick up one by one iris, ciliary body, and choroid, and read them in a little detail, starting with iris first of all, guys. So iris. What do we know about iris? Two simple points. It is a vascular structure. Obviously, because it is a part of uvea, it is a vascular structure. Then we also know it is a pigmented structure. Yes, melanocytes are there, which gives the color. I have brown colored iris, you have brown colored iris with Brad Pitt, Ashwini Rai, they have light blue colored iris. Yes, so that depends on the melanocyte pigmentation. Then iris. Two questions are asked on the thickness of iris. Obviously, if I'm asking the questions of thickness of iris, the first question will be thickest portion of iris and the thinnest portion of iris. The thickest portion of iris is something called as collarette, and the thinnest portion of iris is root of iris. Simple MCQs which you need to learn, but if you want to understand them, then we can see the photograph at the bottom of the screen now, or at the screen now, and we can understand it. So all of us understand the anatomy again and again. I've shown this to you. This is my sclera. This hole is my cornea. Yes. Now behind the cornea we're able to see two things. What are the two things we are able to see? Well, now this is the margin of the pupil. So pupillary margin, which is formed by iris only. Yes. Then this portion of the iris is called the pupillary zone of iris, or the pupillary part of iris, because it is near the pupil. But this portion, this is called as the ciliary zone of iris, because it is near the ciliary body, behind the iris. Behind the iris will be ciliary body. So if this is pupil, this part has been called the pupillary portion, this part has been called the ciliary portion because it is near the ciliary body. Now, the center part, in between both of these, which I will be just drawing in a different color for you, the portion which you can see like a frill, which I am superimposing with purple color, you can see the portion between the, or the boundary between the ciliary zone and the pupillary zone. This is called as the collarette. And this is the thickest portion of the iris. I hope we are clear about this. What do you mean by the root of the iris? Iris behind the sclera would be attached to the ciliary body. Yes. And if this is the iris, guys, and if this is the ciliary body, the iris attaches to the ciliary body. So this point gets to be called as the root of iris. Okay. Now, why is it important as a landmark? Because it is the thinnest part. Now, if iris is attached to the ciliary body, where will it detach from? It will detach from the thinnest part or the weakest part. So the root of iris is the site of iridodialysis. Iridodialysis means detachment of iris. Yes. So because it is thinnest there, that is where it detaches from. This we will study later on again. Yes. So just remember that if you remember simple points of anatomy, basics of anatomy, you are able to use them to learn your clinical science or the questions which are asked as MCQ. So, but again, the basis, the rules, the basics of anatomy of the eye. Alright. Now, I hope you understand the parts of the iris here. Pupillary margin, pupillary zone, ciliary zone, and separated by the collarette. Now, the question comes into my mind: what is iris? What is iris? Is iris a bone tissue? No. Obviously, iris is not a bone tissue. Yes. Iris is a muscular tissue. How do we know that? Sure. So that is known as meiosis or meiosis, whichever way is. So what is the nerve supply? Will be seen. Yes. But is that? I will be revising this with you. What is the sympathetic pathway to the eye through image? Or spinal patch. Okay. All right. So from CA to D1, you can see this turn happening now. From posterior to anterior. Okay. We are crossing over the lung parenchyma and we can be sympathetic. The ptosis. Ptosis is, I hope, drooping of upper eyelid. A very common, fairly common word rather. Ptosis is drooping of upper eyelid. But my question is, why does ptosis occur in Horner syndrome? Now, obviously, you are saying, a lot of you are saying, sir, it will paralysis of LPS, levator palpebrae superioris, but you are wrong. Ptosis in Horner syndrome does not occur due to paralysis of levator palpebrae superioris. Why, sir? Because if you have ever paid attention, levator palpebrae superioris is supplied by third cranial. Now we've just now read, if we didn't know that third cranial nerve is which kind of nerve, parasympathetic. But Horner syndrome is a paralysis of sympathetic pathway. So can LPS be palsied in Horner syndrome? Obviously. Look at it. Ophthalmos means protrusion. In ophthalmos means what? Opposite of protrusion. Protrusion opposite means sunken eyeball. The eyeball sinks inside the orbit. This is not an absolute enophthalmos. This is not a true enophthalmos. So it is called as relative enophthalmos. It just looks like the eyeball is sunken. Actually, the eyeball is not sunken. So that is why it is termed as relative enophthalmos instead of absolute. This one additional point. It is used as a part of an MCQ. Alright. Now, these 5 points all of us know usually. H and I am not so sure. Let's see whether you know. What is H and what is I? Oh, very good. What you are saying? H for heterochromia iridis. Very good. Heterochromia iridis. What do you mean by hetero? Hetero means different. Chromia means color. Iris means iris. So we are saying both iris are of separate colors or different colors. One is dark brown. Please. Palsied. When molars muscle gets palsied, the upper eyelid cannot go up, it goes down. When the inferior tarsal muscle gets palsied, the lower eyelid cannot go down, it goes up. So basically what is happening? If this was the eye which was normally visible between the upper eyelid and the lower eyelid, now the upper eyelid is going down, the lower eyelid is coming up. So the part of eye which is visible is very small. So it is giving the appearance as if somebody has pulled the eyeball inside the orbit of the eyeball has become sunken. And because the eyeball has become sunken, that is why I can see a very small area. That is why the eyelids are up and down. But the eyeball is actually not sunken. The eyeball looks sunken due to inferior eyelid elevation and due to ptosis. That is why we have called it relative enophthalmos. I hope we are pretty clear about the clinical features. HI high, MAP healthy, maple high, maple Horner syndrome. Now, Horner syndrome, we know the causes, we have seen along with the pathway, we know the clinical features. Now, what else do we want to know? If you are suspecting Horner syndrome, can be confirmed, it can be diagnosed through some tests. Yes. So that's our next topic, diagnosis of Horner syndrome. Obviously, Horner syndrome, that's our next topic, diagnosis of Horner syndrome. So to diagnose Turner syndrome, we can do two tests as I written on your screen: 4% cocaine test and 1% apraclonidine test. Two of the tests can be done. 4% cocaine. What is cocaine? Cocaine blocks the reuptake of norepinephrine going to the alpha agonist. It is a non hydroxyamphetamine is promoting the release. HAH I'm writing. Hydroxyamphetamine is promoting the release of norepinephrine into the postsynaptic cleft. Imagine if the syndrome, please remember, topics are constantly repeated. I cannot manufacture new topics to ask questions on. If you understand a topic, the questions will differ. So please always remember Turner syndrome is a very important topic. And obviously, when you read all your videos, you need to know of the high ups. As for Turner syndrome, which we just axillary processes with simply tacos and past is relatively avascular. So the basic anatomy already. What we are interested in here, we are interested here in the functions of ciliary. So what are the functions of ciliary body? There are three functions of ciliary body. Number one, what was written in that diagram for you? Secretion of aqueous through ciliary processes. Number two, the second function was also actually written in the diagram that you had drawn, if you had drawn it, if you had practiced it. Yes. What was the second function? Pars plana provides site of entry into the vitreous cavity as it is relatively avascular. What are we trying to say? We are trying to say that if we want to give an intravitreal injection, if we want to do a surgery inside the vitreous, where is the point of entry? So if we want to do a surgery inside the vitreous, we will want to pierce which part? We will want to pierce the pars plana. Why would we want to pierce the pars plana? Because we know the chances of bleeding will be the least from this part, because this is the most avascular part, and that is what this means. Okay? Now, coming back again, third use. The third use is a very important use, a single word. What is that word? Accommodation. Very important use of ciliary body along with other parts is accommodation. Alright. Before we begin a session on accommodation, I will ask you one simple question. What is accommodation? In terms of, there are two visions here, far vision and near vision. Yes, I can see a far object or I can see a near object. Accommodation is a process which is helping me in far vision or near vision or both. If you're seeing both, you are wrong. If you're seeing near vision, which I think a lot of you are correct. So first of all, what we want to remember is accommodation helps in near vision. Accommodation helps in near vision. That means when we look at a near object, there are certain changes which will take place in the eye. Okay, and that is why we say there is something called as the near reflex. Near reflex is comprised of three parts. Changes will take place in the eye when I look at a near object. A for accommodation, then C for convergence, and then M for meiosis. So the three parts of near reflex are A, C, M: accommodation, convergence, and meiosis. When I look at a near object, these three things will take place in my eye. My eye will accommodate whatever it is we are going to study. My eyes will converge. What is convergence? It's very simple to see. Just look at my eyes. Right now I'm looking at a far object. When I'm looking at a far object, my eyes are straight. Now I look at this pen, everybody. When I look at this pen, notice the movement of my eyes. See, I open my eyes wider for you. Now I will be looking at the pen. When I look at the pen, what do you see in my eye? You see as if both my eyes move inward. You can see the position of my eyes. Both my eyes have moved inward. When both my eyes have moved inward, that means they have converged, that they are trying to meet each other. So we know when we look at a near object, there will be convergence. And thirdly, if you see carefully the pupil will also be constricted, and that's why we can meiosis. What is convergence? I'm just writing for you here. Inward movement of both eyes. Alright, so these are the three parts of near reflex, and out of these three parts, the most important word is accommodation, and that is what we are aiming to understand and study. So to study accommodation, let's use this image. Alright, there are two sets of images you can see on the screen. The image on the left of the screen, this is during far vision, and the image on the right of the screen, this is during near vision. Or basically, this is showing us the process of accommodation which we want to study. Alright, so now if I ask you, out of the two visions, far vision and near vision, what actually is the main, I will not say main, what are our eyes made to do? Are eyes made to do near vision or far vision more also? Yes, obviously. So our eyes are relaxed in the far state of vision. Yes, in the near state of vision, we are doing something, and that is accommodation. So whatever is the far vision state, we are calling it for the purpose of accommodation the normal state, and for near vision accommodation, we are calling it the special state. Okay. So in the normal state of far vision, what can we see? We can see three structures. In the center, we can see the lens. Then attached to the lens, we already know in anatomy, there are thread-like structures called as zonules, and the zonules are attached to the ciliary body. In the ciliary body, the muscle is there, ciliary muscle. I hope you remember this. If you don't remember this, I will again go back to the same image again and again for all of you. See this image? Yes, lens, zonules attached to the ciliary body which has the ciliary muscle. So number 1, number 2 and number 3. Alright. These are the 3 things that we have used in our image also. What can we see during far vision? In far vision we see that the zonules are tense, or I can say the zonules are stretched. Now when the zonules are stretched, what are they doing? They are pulling the lens. When they are pulling the lens, they are making the anterior surface of the lens flat. Compare the anterior surface to the posterior surface. The anterior surface of the lens is flatter, alright, but the posterior surface is curved because the zonules have stretched it. When they have stretched it, the anterior surface has become completely flat, alright. Zonules are stretched. If the zonules are working, the ciliary muscle does not need to work, so the ciliary muscle is relaxed. In this state, what is my visual phenomena? Visual phenomena means parallel rays of light coming from far point. What is the far point? Far point is infinity. Are getting converged onto the retina. Yes. So with my lens flat, parallel rays of light, that's the important word here. Parallel rays of light are getting converged onto the retina so that I can visualize an object. Now the far point is infinity. So infinity means a large area, so from a large area parallel rays of light are coming. Compare this to a near object. A near object is considered to be a point source of object. Okay? When I have a point source of object, what kind of light rays am I expecting? Am I expecting now parallel rays of light, a single ray of light? Or am I expecting now diverging rays of light? Obviously. So because it is a point object, there are diverging light rays. Because there are diverging light rays, which now need to be converged, common sense says the power of the lens needs to be increased. Now the power depends on what? The power depends on Newtonian physics. The power of a lens depends on curvature. The flatter a lens, the lesser the power. The more curved a lens, the more the power. That means for accommodation to look at a near object, because now there are diverging light rays, I need to make the anterior curvature more. I need to increase the anterior curvature, anterior surface more curved. Because if the anterior surface is more curved, then it will increase the power of lens. But how do I make my anterior surface more curved? To make the anterior surface more curved, I will have to stop stretching it. Stretching was again in the zonules. That means now the zonules will become slackened, or I will say the zonules will relax. If the zonules are relaxed, then who is doing the work now? Then obviously the ciliary muscle will need to work now, so the ciliary muscle becomes contracted. I hope we are understanding this. If you are understanding this, let's revise. In accommodation, the anterior curvature needs to increase. For that, the zonules need to relax. For that, the ciliary muscles need to contract. I hope we are pretty clear about this. If we are clear about this, everybody, then again, see the fourth point. What occurs to the antero-posterior diameter? The antero-posterior diameter has visibly increased. So that means point 2, there is point D, there is increase in antero-posterior diameter of the lens also. So all these 4 changes take place together, and when these changes take place, we call it accommodation. So what is accommodation? A change in the power of the lens, or an increase in the power of the lens due to relaxation of zonules and contraction of ciliary muscle, which leads to focus at a near object. I hope we understand what is accommodation in simple terms. Yes? If you still don't understand it, then I will tell you how I have learned it. I hope everybody is able to look at my abdomen. See right now my abdomen, it is curved. It almost always does not move right when I go to a marriage or a party, it is like this. Yes, sir, it is flat. I stretch in my stomach, my zonules are stretched. I stretch in my stomach because I need to see the photographs after some time. I'll get photographs, I'll post it on Insta for other people to see. I need to look smart, so I have far vision. When I have far vision, the anterior surface is flat, the zonules are stretched. But after I have done all the photography, then I see a lot of food. I need to accommodate that food into my gastrointestinal tract. So what do? I can't keep on stretching my zonules. I need to now relax my zonules. As soon as I relax my zonules, see what occurs to the curvature of my lens. My curvature increases, my power to eat food increases. And that is basically what is accommodation. Yes or no? So whenever you stand in front of a mirror, if your abdomen is flat, anterior curvature, you stand far vision. When you flatten it out, the anterior curvature increases, and this is accommodation. Alright? See, this was my anteroposterior diameter during far vision, and this is my anteroposterior diameter during near vision. So you can see the anteroposterior diameter also increases. That's how I always revise accommodation, so that I never forget it. What will be the changes during accommodation? Alright? Now, I hope you will understand it. If yes, then we are going to write down the points now for accommodation. For accommodation, number 1, we are saying the curvature. Which curvature are we talking about? Anterior. Anterior curvature of lens will be increased, or I can say more curved, or I can say more round. Okay. Then increase in curvature occurs due to zonules. What will occur in the zonules? Zonules will relax, or I can say decrease in tension. Number 3, zonules are relaxing, so what has to work? Ciliary muscle. Ciliary muscle will contract. If ciliary muscle contracts, it's a circular muscle, so we can say the ciliary muscle ring diameter is decreased. And finally, we know, as I just now shown you, anteroposterior diameter of lens will be increased, or I can say the lens is thicker. Alright? So these are just the different ways the examiner will use language to ask you questions on accommodation, and that's why I written them like this. In basic fundamental, you understand that radial curvature increases, the zone lab, the muscle contract, and the anteroposterior diameter increases. But after that, it is just use of English. As I always say to all my students, MBBS is more than 50% English. If you understand English, if you know English, if you know how to use the English, if you know the meaning of each word, then anyways 90% things which you find difficult generally you start to understand. Right? When you start to understand, learning becomes easy, and that is why half of your job is done in MBBS. We struggle with our language, we struggle with English, and that is one of the main hindrances in understanding. So always focus on the meaning of the words, try to further vocabulary. And when I say vocabulary, I mean to say medical English vocabulary. The more you understand each word, the more you will be able to remember that. Now, once we are through with how normal accommodation works, what we need to know, anomalies of accommodation. Yes, so we understand what is accommodation. Accommodation is basically two things, as we have said, helps in near vision, and if I can expand it further, by increasing